สวัสดีครับ So now we move to the next session. Is the first symposium in a TSCO annual meeting this year. This symposium from Serbia about the recent advance in the management of second-line metastatic pancreatic cancer from bench to bedside and beyond. So first, let me introduce our speaker, Dr. Chigusa Morisane. Dr. Chigusa Morisane is Assistant Chief Department of Hepatobiliary and Pancreatic Oncology, National Cancer Center Hospital since 2017. His area of interest is hepatobiliary and pancreatic oncology. Today, Professor Morisane will give a talk about the treatment optimization of metastatic pancreatic cancer from clinical data to real-time practice. Please welcome Professor Morisane.
Hello everyone, my name is Chigusa Morisane from National Cancer Center Hospital. I would like to thank the chairperson of TISCO and the moderator, Professor Eka Hope, and the sponsor Serbia for giving me this opportunity and this presentation. I would like to talk about recent advances in the management of second-line metastatic pancreatic cancer. Age-adjusted age-adjusted incidence and the mortality of pancreatic cancer is gradually increasing in Japan. Pancreatic cancer is common among the elderly and, as you know, has a very poor prognosis. In addition, Japan has a high incidence of pancreatic cancer worldwide. In addition, the microenvironment of pancreatic cancer is characterized by a large amount of stroma and an abundance of tumor-associated macrophages. These characteristics are thought to be associated with reduced drug delivery, which results in the resistance to the chemotherapy. These are the NCCN guidelines for pancreatic cancer. For example, systematic therapy for the pancreatic cancer with distant metastasis is also provides the detailed treatment strategy for first-line and second-line setting. Here is the Japanese guideline for pancreatic cancer treatment. You can read the summary in the International Journal of Clinical Oncology. Borderline resectable and URLA are treated with chemotherapy or chemoradiotherapy. Specific algorithms are available for stage 4 systemic chemotherapy. FOLFIRINOX or GEM plus nab-paclitaxel is a first choice for first-line treatment. And if those two treatments are not suitable, gemcitabine monotherapy or S1 monotherapy is a treatment of choice. This guideline also features a treatment strategy for elderly patients. The guideline also suggests a treatment strategy for the second-line setting. After the gem-containing regimen, 5-FU plus nano-liposomal irinotecan combination therapy or 5-FU containing regimen is recommended. After the gemcitabine containing regimen, after the fluorouracil containing regimen, the gem containing regimen as a second-line setting is recommended. First, I will present a randomized Japanese trial in locally advanced pancreatic cancer. This is a randomized phase 2 trial of modified FOLFIRINOX and GEM plus nab-paclitaxel. Metastatic-free survival tended to be better in FOLFIRINOX. However, on the other hand, gemcitabine plus nab-paclitaxel demonstrated better response rate, disease control rate, and CA19-9 response. So, as a conclusion, the modified FOLFIRINOX and gem-nab-paclitaxel displayed comparable efficacy and safety for locally advanced pancreatic cancer. Now, let's move on to the next topic, metastatic pancreatic cancers. Here is a pivotal study called ACCORD-11 trial conducted in France. In this RCT, FOLFIRINOX shows a significant survival benefit on gemcitabine monotherapy. However, as you know, the original FOLFIRINOX regimen has strong side effects, and modified FOLFIRINOX, which omits the 5-FU bolus dosing and reduce the irinotecan dose to 150 milligrams per square meter, is relatively well liked and used internationally. Here is a side-by-side list showing the effect and adverse events of ACCORD-11, a Japanese phase 2 of original FOLFIRINOX and Japanese phase 2 of modified FOLFIRINOX. Efficacy data of modified FOLFIRINOX is comparable on the other hand, compared to other regimens. On the other hand, myelosuppression or febrile neutropenia and gastrointestinal toxicity was lower when compared to the original FOLFIRINOX regimen. Next, here is the randomized control trial called the MPACT trial that shows the significant superiority of gemcitabine plus nab-paclitaxel over gem monotherapy. Median survival of gem plus nab-paclitaxel was 8.5 months. This is the JCOG 1611 study that has been conducted in Japan. It is a 3-arm phase 3 RCT comparing the modified FOLFIRINOX and gemcitabine plus nab-paclitaxel and S1 plus oxaliplatin plus irinotecan called SIROX regimen. Result will be presented at this ESMO meeting. Recently, the Napoli-3 trial, which demonstrated a significant life-prolonging effect of NALIRIFOX versus gem plus nab-paclitaxel, is also very important and would be a game changer of metastatic pancreatic cancer practice. However, the Napoli-3 regimen has not yet been approved in Japan. Olaparib has been shown to be useful as a genome medicine in pancreatic cancer. The POLO study, a randomized control phase 3 trial, comparing the olaparib versus placebo after 16 weeks of disease control with a platinum-based regimen in patients with germline BRCA mutation, positive URM pancreatic cancer patients. This trial shows a significant prolongation of PFS in the olaparib group. Now I'm going to talk about the second-line treatment. This is the Japanese guideline I showed you previously. NALIRI-5-FU leucovorin and fluorouracil-containing regimen are recommended as a second-line therapy after the first-line gem-containing regimen. Conversely, gem-containing regimen is recommended as a second-line therapy after the first-line fluorouracil-containing regimen. Here is a conceptual illustration of nanoliposomal irinotecan. The liposomal bilayer protects the irinotecan from conversion to its active metabolites, SN38, in the circulation, thereby the increasing intratumoral levels of both irinotecan and SN38. Local metabolic activation increases its therapeutic window and potentially minimize toxicity. In addition to that, EPR effects have also been reported. Drug containing nanoparticles easily leak from the tumor blood vessel with increased vascular permeability and selectivity reach and accumulate in the tumor tissue. And here is the study design of the NAPOLI-1 trial, which provided the usefulness of NARO-ED plus 5-FU-leucovorin in second-line therapy. The trial initially compared 5-FU-leucovorin to nano-ED monotherapy, but thereafter the NARO-ED 5-FU-leucovorin arm was added. Here are the results. As you all know, the NARO-ED 5-FU-leucovorin group shows a significant life-prolonging effect compared to the 5-FU folic acid group. This result was also confirmed by the long-time follow-up. Additionally, subgroup analysis of NAPOLI-1 study indicated that there were also advantages of NARO-ED-FF in prolongation of OS and PFS. Here is the safety profile of the NAPOLI-1 regimen. Diarrhea, vomiting, and nausea, and loss of appetite were the main side effects. Here is the real-world data of selected regimen for metastatic pancreatic cancer at the National Cancer Center. Gemcitabine plus nab-paclitaxel is more frequently chosen than modified FOLFIRINOX as a primary first-line treatment regimen. Looking at the breakdown by period, the overall population of modified FOLFIRINOX use appears to be higher in Japan due to this period. FOLFIRINOX use appears to be higher in Japan due to the nab-paclitaxel outage. However, the Gem plus nab-paclitaxel is currently the main choice in daily practice in Japan, including at our institution or other than ours institutions. And here is a breakdown of the regimens of choice for second-line treatment after each first-line treatment. Napoli regimen was more common than modified FOLFIRINOX as a second-line treatment for patients treated with first-line gem-nab-paclitaxel. And most patients treated with gem-nab-paclitaxel after the first-line modified FOLFIRINOX. As NARO-ED was launched in Japan on June 2020. Here is a breakdown of regimens of selected as second-line treatment after gem-nab-paclitaxel since June 2020. NARO-ED 5-FU folic acid has been selected more frequently in more recent years. One of the important clinical questions is whether NARO-ED plus 5-FU is effective in patients with a history of irinotecan administration. These survival curves show the PFS and OS of patients who underwent NARO-ED 5-FU at our institution with and without history of irinotecan administration. Although these data has a much selected patients, but treatment efficacy seems similar. Furthermore, I have heard that FOLFIRINOX is often performed as primary first-line treatment in Thailand. So we picked up a patient who received FOLFIRINOX as a first-line treatment, gem-containing regimen as a second-line treatment, and thereafter Napoli 5-FU as a third-line treatment at our institution. I expected much worse outcome, but some patients had somewhat longer PFS from the initiation of NARU-ED, and some patients have survived more than 1 year from the initiation of NARU-ED. Okay. And now I would like to talk about the supportive treatment when administrating NARU-ED and FOLFIRINOX in daily practice. Professor Ekapok had kindly introduced me the original paper about UGT1A1 in Thailand. And the paper indicated that UGT1A1 double variant is not so common in Thailand. On the other hand, about 10% of patients in Japan are known to have double variant of UGT1A1. Patients with double variants were at high risk for the adverse event of diarrhea and neutropenia and should be administered at reduced dose. The guideline for NARU-ED to reduce the 70 mg per square meter to 50 mg per square meter. There are no clear guidelines for irinotecan dose reduction in FOLFIRINOX. In addition, a Shibu port is implanted to enable continuous infusion of 5-FU over a long period of time. It is important to note that pinch-off occlusion due to the thrombus and other problems can occur during the Shibu port insertion. And peripheral neuropathy is also an important adverse effect that can accumulate in FOLFIRINOX regimen due to usage of oxaliplatin. Oxaliplatin in this peripheral neuropathy is known as neuronopathy. And it essentially irreversible, requiring attempts alleviate symptoms with pregabalin, gabapentin, or Gosa Jinkigan, Chinese herbal medicine. Cholinergic symptoms may occur when using NARU-ED or irinotecan, including sweating, slurring of speech, and abdominal discomfort. Cholinergic symptoms should be treated with atropine sulfate and prophylaxis at the next administration. Contraindication to atropine use, such as glaucoma, should also be noted. As for antiemetic therapy, the National Cancer Center offers prophylactic administration of FOLFIRINOX as a high emetic risk and NARU-ED5-FU leucovorin as intermediate emetic risk. Since pancreatic cancer patients are often complicated by diabetes mellitus, be careful about the elevated blood glucose level when steroid or olanzapine use. Finally, I will also briefly introduce the expected genome medicine for pancreatic cancer in the future. Previously, I talked about the germline BRCA, but here I would like to talk about somatic mutation. More than 9% of pancreatic cancer patients have a somatic mutation of KRAS. Pancreatic cancer with KRAS wild type, which is a minority, is often found to harbor targetable genetic alterations, such as NRG fusion or BRAF fusion or FGFR fusion or MSI high. Additionally, the anti-EGF antibody, nivolumab, was there one positive data of RCT. And in addition, KRAS inhibitors not only G12C, but also the G12D and pan-KRAS inhibition are expected to be in early development. As a summary, here is an overview of systematic therapies for patients with advanced pancreatic cancer. Thank you for your attention.
Thank you, Professor Morisani, for comprehensive review. So next, let me introduce the next speaker, Associate Professor Kitiya Paisan. Everyone know her already, so she's going to give a talk about the practical consideration in first line and second line treatment for pancreatic adenocarcinoma. Dr. Kitiya, please.
Okay, thank you so much, Dr. Ekapol, for your kind introduction. And I would like to thank Xavier for inviting me to present this topic, the practical consideration in the treatment of advanced pancreatic cancer. Here's my disclosure. So before we discuss about the practical considerations, I will talk about the fact in pancreatic cancer. Firstly, 10% of the pancreatic cancer are hereditary disease, even if they have no family history of cancer. So this is important because of the germline BRCA mutant can reflect the first-line treatment option and also the maintenance treatment. Secondly, the stage by stage. Pancreatic cancer have a lowest survival rate when compared with the other common cancer. So, and we have no cancer screening program available for pancreatic cancer. So more than 70% of the patients presented with inoperable at time of diagnosis, either locally advanced unresectable disease or metastatic disease. And as everyone knows that the median survival of pancreatic cancer was just around 4 to 6 months. Moreover, the poor response to conventional chemotherapy and immunotherapy were ineffective. So far, no targeted therapy approved in the first-line setting. So this fact represents that the pancreatic cancer is a very aggressive disease and there were several unmet needs in the pancreatic cancer treatment. For therapeutic goal in this disease, I will not focus only for the prolonged survival, but we should include the symptom control, prevention of the complication, and also primary maintain quality of life. That means if the treatment can control the patient's symptom, this is worth enough to start in the patients. If we move to the first-line cancer therapy treatment, in the current guideline, in the patients who have ECOG performance status 0 to 1, the recommendations still be the FOLFIRINOX, Gem/Nab-Pac, and more recently, the NALIRIFOX. Moreover, in the patients who have a germline BRCA mutation, you can use either FOLFIRINOX or cisplatin plus gemcitabine, because this regimen is a platinum-containing regimen and this will respond well to the treatment. Here is the summary data of the all combination treatment in the frontline setting. These two studies, PRODIGE and MPACT study, compare with the gemcitabine monotherapy. PRODIGE study evaluate FOLFIRINOX and Gem/Nab-Pac evaluate MPACT evaluate Gem/Nab-Pac. If you see in the detail in this study, they include the patient's only ECOG performance status 0 to 1, except for the Gem/Nab-Pac that include the patient with ECOG performance status 2 around 8%. The FOLFIRINOX restrict the age of the patients in this study with less than 75%. However, the list of two Gem/Nab-Pac and NALIRIFOX will not restrict the age inclusion. If we're focusing on the objective response rate from the first two studies, I will talk about the first two first because of they compare with the gemcitabine monotherapy. The objective response rate of gemcitabine, you can imagine that it's just around 10%. However, when compared with the FOLFIRINOX, the objective response rate were as high as 30% and 20% in the GEM-NAPPAC. These two studies demonstrate improvement in overall survival and progression-free survival over gemcitabine monotherapy, and they become the standard of care. However, in our practice, we have two choices. So what is the regimen preferred over the another regimen? So if you go back to check the hazard ratio of these two, you're going to see that the median overall survival for FOLFIRINOX with a hazard ratio of 0.57 compared with 0.72. So in the practice, FOLFIRINOX is a preferable regimen over gemcitabine. But again, this is a cross-trial comparison. For the NAPOLI-3, this is the first randomized study that evaluates the combination over the combinations. This is a NALIRIFOX and GEM-NAPPAC. For the objective response rate of the study in the GEM-NAPPAC in the NAPOLI is 36%. If you're looking at the IMPACT study, it's slightly higher in the IMPACT study, which was around only 23%. But if you see the median progression-free survival in the GEM-NAPPAC, which is the standard arm in the NAPOLI-3, it's pretty much the same number when compared with the IMPACT study. For the overall survival, NALIRIFOX demonstrates improvement in overall survival over GEM-NAPPAC with a hazard ratio of 0.83. Again, if you see the number, it's pretty much the same as the FOLFIRINOX. After the NAPOLI study presented, it supports the use of either FOLFIRINOX or NALIRIFOX as a frontline setting, and maybe put the GEM-NAP as a second line. If you're focusing on the patients who have an ECOG performance status 2, you can use either GEM-NAPPAC-Taxol. Because of I present earlier, in the IMPACT study, they include the patients who have ECOG performance status 2 around 8%. This supports the use of GEM-NAPPAC in the PS2. Or you can use either monotherapy of the capecitabine, gemcitabine, and TS1. The recommendation supported by the data from the SPAC study, which is present since 1990. The gemcitabine improved in overall survival compared with 5-FU monotherapy and led to the global improvement in the frontline treatment. For the data from another data from JET study, which was conducted in Japan populations, they have a 3-arm randomization and would like to test the non-inferiority of TS1 over gemcitabine and test the superiority of GEM-TS1 over gemcitabine. Looking at the combination first, even if the GEM-TS1 demonstrates improved in the overall objective response rate and PFS, but it failed to demonstrate superiority over the gemcitabine, so this is a negative. When focusing on the monotherapy of TS1 and gemcitabine, TS1 met the non-inferiority endpoint of OS and PFS. That is why it's become approved in Japan population, but not the global approved because of this study was conducted only in Japan. For the patients who have ECOG performance status 3, normally in the other cancer type, we will not offer for the chemotherapy, but we will put the patient into the best supportive care. But pancreatic cancer, this is a very aggressive disease. In the guideline, they still recommend to use gemcitabine monotherapy. The question is why they still recommend this regimen. If you go back to see the result of the SPAC study, gemcitabine not only demonstrates the superiority over 5-FU, but it also demonstrates clinical benefit response, which is the composite measurement of the pain, Karnofsky performance status, and also weight over the 5-FU. That is why the guidelines still will recommend gemcitabine monotherapy in this setting. If we move to the key safety data, because in the frontline treatment, we have 3 treatment options. So we have to know about how different with the side effect. This is the selected grade 3 or more adverse event in each regimen. If you see in the detail, you're going to see that the grade 3 or more for neutropenia was more commonly seen in the FOLFIRINOX, followed by GEM-NAPPAC and NALIRIFOX. However, the rate of febrile neutropenia is less than 5% in all of the regimen. The side effect about the sensory neuropathy is more common seen in Gem/nab-paclitaxel over the FOLFIRINOX and NALIRIFOX. This is a cross-trial comparison, but we can see the trend. The question is it very interesting that NALIRIFOX have a less side effect of neutropenia and sensory neuropathy. The question again, the reason why it's happened like this. If you see the dose of the oxalipatin, you're gonna see that the NALIRIFOX used only 60 milligram of oxalipatin per meter square, and the dose of nanosomal irinotecan was only 50 milligram per meter square. This is led to the less toxicity of neutropenia and neuropathy. However, the most important thing is that you need to know about the side effect of NALIRIFOX is the severe diarrhea. And it's more than, it's happened in the FOLFIRINOX too. It's around 20% that develop grade 3 diarrhea. So if we combine taking all the efficacy data and safety data together, we have to incorporate another factor to be considered before the start of treatment, including the patient performance status, age, comorbidity, including the patient who have preceding sensory neuropathy, patient preference, and again, the predictive biomarker, especially for the BRCA gene mutations. This is a slide that I summarized the guideline that if we see the patient that in our clinic and we have no plan for chemotherapy, in this case we will put the patients into the best supportive care. However, if we still plan to use the chemotherapy, we have to evaluate that the patient fit to combination or single agent. If the patient fit for the combination and ECOG performance status 0 to 1, the data support using FOLFIRINOX or NALIRIFOX. And again, you have to keep in mind that we have no data in the patients who have the age more than 75 in FOLFIRINOX regimen. In the patient who have ECOG performance status 2 and still fit for the combination, Gem/nab-pac is the recommended regimen. In the patient who fit for only single agent chemotherapy and ECOG performance status 2, the guidelines still recommend gemcitabine or 5-FU or TS1. About the patients who have the very poor performance status, you can do either discuss with the patients and evaluate whether put the patient to best supportive care or still be using the gemcitabine. And this is important again to know that less than 50% of the patient will be fit enough to receive second-line chemotherapy. So I think this is the best treatment option upfront is a key for pancreatic cancer treatment. For the tip of each regimen, if you use FOLFIRINOX, again, you fit in the patient ECOG performance status 0 to 1, and we prefer modified FOLFIRINOX more than original FOLFIRINOX regimen, which decrease the dose of irinotecan from 180 to 150 and omit the bolus 5-FU. And generally, G-CSF is generally not recommended, but in the practice, you may be used in the patients who have the old age and multiple comorbidities. For NALIRIFOX, again, it's restricted to the patient with ECOG performance status 0 to 1. However, no age restriction in this regimen. Even if they have less side effects about neutropenia and neuropathy, but you have to keep in mind that the toxicity about diarrhea will more commonly seen compared with FOLFIRINOX. And I recommend to use loperamide and advise the patient about this side effect. And again, because of NALIRIFOX is not available in Thailand, we don't even know about the cost. Because if the two regimens have the same efficacy, the cost will be another factor. For the gemcitabine, you can use in the patient with ECOG performance status 0 to 2, and be aware in the patients who have the pre-existing neuropathy because of the side effect. So I will move to the maintenance therapy really quick. In the patients who have the response well to the first line treatment for maybe 4 to 6 months, we can consider for the maintenance therapy. But don't think too much because of most of the clinical trial, the median progression-free survival in the first line was just around 7 months. So in this setting, if you start with FOLFIRINOX, you can just omit the oxaliplatin and continue the FOLFIRI, or you can either use monotherapy of capecitabine or 5-FU. If you start with the gemcitabine and nab-paclitaxel, you can omit the nab-paclitaxel and continue the gemcitabine. And of course, in the patient with germline BRCA and still respond after 4 months, you can use olaparib according to the POLO study that olaparib improved median progression-free from 3.8 to 7.4 months. So for the second line setting, I will not touch much because Dr. Molisane mentioned earlier that the preferable regimen will be NAPOLI-1. Again, NAPOLI-1 include the patients who receive prior gemcitabine, not FOLFIRINOX. And another treatment combination will be adding oxaliplatin. However, in the oxaliplatin containing regimen, we have 2 pivotal trials, CONGO 003 and PANCREATOX study. And only CONGO 003 demonstrate overall survival benefit over in oxaliplatin-based regimen over 5-FU monotherapy. But in PANCREATOX study, adding oxaliplatin in the modified FOLFIRINOX did not improve in overall survival, and actually it's detrimental effect of the treatment as well. However, several factors that the author trying to explain because of difference in the patient characteristic of PS2 more in the FOLFIRINOX and subsequent treatment in the patient who not more the FOLFIRINOX. FOLFOX, and the subsequent treatment of the FOLFOX arm will less than 5-FU arm, and moreover, this study have a crossover study. So from this combination, NAPOLI-1 become the treatment of choice, not FOLFOX, because of the conflict result. Again, for now, we start with the first line for FOLFIRINOX. The question is, what about the second line after FOLFIRINOX? So far, we have no randomized study evaluate the second line treatment. But in the practice, gemcitabine and nab-paclitaxel can be used in this setting. This data come from the small prospective and retrospective study demonstrate the objective response rate of gem-nab-pac in the second line setting around 15% and the median progression-free survival around 4%. This is all we have so far. So we will use gem-nab-pac in the patient who still fit for the combination. So I will finish my talk here with this slide. This is a summary of the sequencing therapy in advanced disease. So the first line treatment, we're gonna start with NALIRIFOX or FOLFIRINOX, which is a modified version. And if the patient progress, we can use gem-nab-pac or gemcitabine monotherapy if the patient's decline performance status. And if you start with gem-nab-pac, you can use nanosomal irinotecan plus 5-FU according to NAPOLI-1. And if nanosomal irinotecan is not available in the country, especially in Thailand, you can use either FOLFIRI or FOLFOX. And germline testing is recommended in every patient with pancreatic cancer to identify the patient who get the benefit from platinum-based chemotherapy and the BRCA inhibitor and PARP inhibitors. For somatic mutation can be considered only in the patients who can afford to the targeted therapy to identify the rare alterations. Thank you.
Thank you. Thank you, Professor Kitiya, for excellent talk. So now it's a Q&A session. Is there any question from the floor? So let me start with a question for Professor Morisane. In Thailand, many patients receive adjuvant FOLFIRINOX. So if finally they got recurrent disease, this adjuvant FOLFIRINOX is not eligible for NAPOLI-1 and NAPOLI-3. So which regimen would you consider? Will you consider NALIRIFOX or NALIRI in this group of patients?
Oh, yes. In Japan, the adjuvant setting FOLFIRINOX is not allowed. So we use S1 monotherapy as adjuvant setting. So that the situation is quite different. But I think that if the patient receives modified FOLFIRINOX, the disease-free period is important, I think. So more than 6 months or longer, maybe the retry the modified FOLFIRINOX or NALIRIFOX is available. However, the short-term recurrence was occurred. Gemcitabine monotherapy or gem/nab-paclitaxel is suitable, I think.
And about second line treatment.
And after the gemcitabine containing regimen was started, the second line, so we should consider about the naru-irinotecan plus 5-FU lycopene is suitable because they do not use non-liposomal irinotecan yet. So after the FOLFIRINOX as a first line, maybe second line should be the gemcitabine containing regimen, gem monotherapy or gem/nab-paclitaxel. I think so.
You mentioned about the UGT1A1 polymorphism in Japan and also in Thailand. And what would you think that every patient should be tested for UGT1A1 before receiving nano-liposomal irinotecan?
In Japan, I presented previously that about 10% of patients has a double variant of UGT1A1. So all patients receiving the chemotherapy should be tested for UGT1A1 status. And in fact, we check the UGT1 status before the NALIRIFOX or FOLFIRINOX.
So let me ask Dr. Kitiya, because FOLFIRINOX is a lot cheaper. So what would you consider for first line treatment? Which one should receive NALIRIFOX? Which one should receive FOLFIRINOX?
I think according to the efficacy data, no one didn't agree that the efficacy data is pretty much the same. I will consider about the side effect because if the patients have a already old age, maybe let's say more than 80 or 75 years old and have the baseline neutropenia, so I prefer using NALIRIFOX because of the side effect. And the cost as well that I mentioned earlier because we have no nanosomal irinotecan available so far, and irinotecan is very cheap right now. If the efficacy still be the same, but the cost is very high, so I think I prefer using FOLFIRINOX more than NALIRIFOX.
Thank you. Is there any more question? Dr. Vishen, please.
Is there any study comparing now irinotecan with conventional irinotecan?
No. This is a question in the ASCO meeting that why don't they trying to compare between the NALIRIFOX and FOLFIRINOX because of this is a commonly used regimen in the worldwide. But in some country, the gem/nab-pac still be the first treatment option in this setting. That is why they compare with the gem/nab-pac. But I'm not sure about it in Japan. Do you have any direct comparison between NALIRIFOX and FOLFIRINOX?
Okay, when thinking about economical effect, the naru-irinotecan comparing the original irinotecan is very important. So the upcoming ESMO meeting, the JCOG 1611 clinical trial comparing FOLFIRINOX and gem/nab-paclitaxel and SIROX will be presented at the ESMO meeting, which is very important things. But about the clinical question, naru-irinotecan is same as original irinotecan because we can check the result of modified FOLFIRINOX versus Gemna paclitaxel. So you should check the results.
Thank you. If there's no any question, I would like to thank both speaker, Professor Morisani and Professor Kitiya for excellent talk today. I would like to close this session. Thank you. เดี๋ยวจะเป็น